Okay, I'm live. Here we go. You might hear a lot of sound in the background. I got a big mastiff chasing my cat. So that's what all that rumbling is. So we're going to get right into it. I don't know what page I'm on, but I'm about 17% in my book. I've been reading like crazy all day today. And I'm going to just pick it up. So I'll give a little context for anyone who cares. So I just got done reading so I went over radial access. Oh, okay, you have to go poop? All right, go for it. So we did radial access, and we went over everything with radial access from start to finish. And then I just got done with femoral arterial access, and now we're getting into femoral venous access and landmarks and finger placement and basically how to access it appropriately. So I'm just going to start where I'm at. Let me see, where did I start? When I finished. Vein has not been entered. Flesh, okay, I talked about that. Several attempts may be necessary. Okay, I talked about that. Ultrasound imaging guidance, okay. A vein that has been entered mistakenly during a femoral artery puncture. So that was the thing too that I was talking about, is that. So, and we'll just talk about it. So you have your anterior superior iliac spine, and then you have your pubic symphysis, and then you have your the ligament that connects the two. And so you'll find that ligament. So landmarking, you'll find the ligament, and then just go about 2 centimeters down, kind of right in the middle between the two, and you'll feel the pulse of the femoral artery. And then just medial and proximal, just medial and proximal, you'll have the vein. So as you'll feel the pulsation of the artery, you'll just go medial about 1 centimeter, and then you'll start kind of digging around for the vein there. And then once you get non-pulsatile dark blood filling the syringe on the micropuncture or whatever it is that you're using in the cannula, then you'll know you're in the vein. If the vein has been entered mistakenly during a femoral artery puncture, attempt should be used only if the needle tip did not puncture both walls of the artery and go into the vein behind it. So that's the other thing, is it can be behind the artery. So you have to, it makes sense. Ultrasound is the best way to do it. Placing a sheath through the artery into the vein may create an AV fistula, and that's not good, or cause uncontrolled bleeding from a large hole in the posterior wall of the femoral artery. The remainder of the venous sheath placement is completed in the same fashion described for the femoral artery sheath insertion. Okay, so I'm not going to go over that. After the calcification is complete, finger pressure is applied. Finger pressure is applied over the vein as described for femoral artery sheath removal, although much less pressure is needed. After percutaneous femoral vein puncture, 5 to 10 minutes of compression is usually enough time to obtain adequate hemostasis. Note for accessing both femoral artery and vein. So for cases in which right and left heart catheterization is planned, a method of vascular access can be modified from the standard approach described previously. In some laboratories, venous access is performed first, but instead of proceeding to insert a sheath after the wire is introduced, the wire remains in the vein until the artery has been punctured and the artery guide wire is in place. The insertion of the sheath then follows after the skin nicks are made. The sheaths are inserted both over each wire sequentially, usually vein then artery. The advantage of this minor change is the elimination of a chance to puncture the venous plastic sheath while searching with the needle for the nearby artery. Oh my, okay, so that makes sense. And I've seen that where they'll do, so I had one patient who they were going to place, so this is what happened. So patient came in, he had like a 90% occlusion of his RCA, I think. Was it RCA? Yeah. So RCA, and he was, I don't know, I would say symptomatically Brady. I don't know if he was symptomatically Brady, but he was really Brady, like 45s. And they were going to rotoblade the occlusion. because it was like a calcification. And so the rotoblade is like a diamond tipped blade that runs into the coronary artery, and then every, like, I don't know how many revolutions per minute, but like some revolutions every few minutes, it just slowly grinds away, and then you can place so once you've gotten all the way through, you place like a drug-eluting stent, and then he used RFR to determine if it was fitted correctly. Anyways, the point of the matter is, it's sitting there in the right coronary, right coronary artery, the big right coronary. It's sitting there going, buzzing the occlusion, and while it's doing that, there's no blood flow distal to that rotoblade buzzing, because it's a diamond tip blade. There's no blood flow, and so what they did was they venous paced him while that was happening. So they had to access the vein and access the artery. Trying to think. On that one, I don't think he accessed the both right artery and the right femoral artery and the right femoral vein. I think he went right femoral vein and left femoral artery. And so he transcutaneously paced at 40 while he was rotoblading the RCA and placing the stent and all that stuff. So I'm just thinking back now, and I'm thinking, maybe he didn't access both right femoral vein and femoral artery. But I have had them where they have accessed right femoral vein and right femoral artery at the same time, and that's totally doable. So that's a little, I guess, clinical correlate for myself. So patient awareness. For both radial and femoral access, 3 steps may be associated with pain and vagal reaction. 1, initial administration of lidocaine, okay, because that's the first prick. Arterial needle insertion, okay, because that can be uncomfortable. Sheath assembly advancement, which is this huge straw Cordis 5 or 6 French plastic spike that goes into your wrist. And sheath assembly advancement. The operator should monitor the heart rate and feel the strength of the arterial pulse to detect early vagal response, as vagal reaction of hypotension can occur with no change in heart rate, most commonly in elderly patients. Yeah. Hemostasis after catheter and sheath removal. Okay, so after catheterization has been completed, the patient's blood pressure is monitored and the catheter is removed. The sheath is aspirated and flushed to clear any thrombi. The patient is transferred to a holding area on a stretcher. If heparin has been given during the procedure, an active ACT and activated clotting time is obtained. Protocols vary, but the sheath is generally not removed until the ACT falls below 200. I don't think that's how we do it. To remove the sheath, the operator places his or her fingers over the femoral artery. Because the actual puncture site is more cranial, toward the patient's head than the skin incision. So let's read that. So over the femoral artery. So let me just read that one more time. To remove the sheath, the operator places his or her fingers over the femoral artery because the actual puncture site is more cranial than the skin incision. The operator's fingers should be placed over the femoral artery above the skin puncture site. Yeah, that makes sense. The operator applies gentle pressure and removes the sheath from the leg, taking care not to crush the sheath and strip, quote unquote, strip clot into the distal artery. Jeez. When a small spurt of blood purges the arterial site and site of retained thrombi. So when a small spurt of blood purges the arterial site of remained thrombi, the operator should apply firm downward pressure. Firm 3-finger pressure should control most femoral bleeding. A rolled gauze pack may be placed over the artery to the groin and pressure applied with the palm of the hand. I've done that. Standing on a short stool at bedside permits the operator's upper body weight to be used for pressure application. Yeah, so that's the way I always did it. Manual pressure is held firmly for approximately 5 minutes per sheath size. Therefore, a 25 minutes for a 5 French. 5 minutes per sheath size. Okay, therefore, 25 minutes for a 5 French, 30 minutes for a 6 French. In patients receiving antiplatelet treatment, aspirin or clopidogrel, longer puncture site compression may be necessary. Compression time should be divided into 4 periods: full pressure, 3/4 pressure, half pressure, and 1/4 pressure over the prescribed duration. During pressure application, pedal pulses should be intermittently evaluated. An entire leg should be uncovered to identify duskiness of the extremity. A diminished pulse is acceptable during brief full pressure application, but distal pulses should not be obliterated completely at any time during manual compression. If the pedal pulse is absent during compression, the pressure over the artery should be decreased slightly periodically to allow distal circulation. Complete artery occlusion prevents clotting factors and platelets from being deposited at the arterial wall puncture site, and in extreme cases can lead to thrombotic events, particularly in lower extremity bypass grafts. In patients with low cardiac output, mitral stenosis, or cardiomyopathy with a small pulse pressure, the femoral artery can easily be obliterated. In these patients, distal pulses should be checked more often and less pressure should be applied into the groin. Okay, I'm good with all that. Okay. Hematoma monitoring and groin dressing. Hang on a second. Okay, after an appropriate time for manual pressure, the operator's hand is removed slowly and the area is inspected for hematoma or bleeding. Hemostasis may be difficult to secure in obese, hypertensive, or elderly female patients, or in patients with aortic insufficiency. Likewise, patients with a coagulopathy or who are receiving anticoagulant or antiplatelet agents may take longer for hemostasis. Okay, that's kind of a given. In all such patients, an extended monitoring period is prudent. Absolutely. In larger patients, greater than 500 mils of blood can be lost in a thigh or pannus before the patient or nurse identifies the problem. Yeah, that's what's scary. After hemostasis is obtained, clean the puncture area with an antiseptic solution and apply a small, clear, sterile dressing, opsite or tegaderm. This permits visualization of the entry site and surrounding tissue. One should not use gauze under the plastic dressing because this forms a culture media if left in place after discharge. Okay. Small, clear, sterile dressing. So we use a gauze. We'll use a 4x4 and we'll put a 4x4 square, tiny little 4x4. We'll roll it up into like a half by half. And then we'll put a tegaderm with that pressing at the puncture site. So I don't know if that's best practice, but that's what we do. This permits visualization of the entry at that. Okay. Likewise, large pressure dressings or sandbags should not be used because they are insufficient in preventing bleeding and obscure the puncture site so that early hematoma formation may be missed. If the femoral artery and vein are used in the procedure, one should ensure arterial hemostasis first and then remove the venous sheath to decrease the risk of AV fistula. Let me read that again. If the femoral artery and the vein are used in the puncture, one should ensure arterial hemostasis first and then remove the venous sheath to decrease risk of AV fistula formation. In addition, preservation of venous access for the first 15 minutes of arterial compression may provide a useful access to treat a vagal reaction should the peripheral RV line be inadequate for a large volume resuscitation. Yeah, I think that makes a lot of sense. If you have two cordis lines, one in the art and one in the vein, you want to make sure you got good hemostasis and you have hemodynamic instability. Keep that 5 French freaking venous sheath because if you have to, you can run fluids all day through that thing, or you can do anything with that. So that's something. Mechanical compression and vascular closure devices. Okay, yeah, FemStop pressure systems. Okay, so I've used this. The FemStop is an air-filled clear plastic compressible bubble that molds to skin contours. It is held in place by straps passing around the hips. The amount of pressure, the applied pressure is controlled with a sphygmometer gauge. The clear plastic dome allows the operator to see the puncture site. The FemStop is used most often for patients whom prolonged compression is anticipated and whose bleeding persists despite prolonged manual compression. The duration of the FemStop, compression, and time until removal of the device vary depending on the patient and staff protocols. In some hospitals, the time from application to removal may be less than 30 minutes. In other patients to whom the hemostasis is required, the device may be left at lower pressure for a longer duration. During the entire time of placement, direct visualization and monitoring should be performed by a trained individual. I think we do 15 minutes. Yeah, I've done the FemStops. I think we do 15 minutes at a time. I don't know. It doesn't matter. Use of a FemStop pressure system before proceeding. Examine the puncture site carefully. Note the mark edges of any hematoma. Yeah, note and mark edges of any. Yeah, big time. Or even bleeding. So yeah, okay, we'll just keep going. And record patient's current blood pressure. Absolutely. A and B. So step 1, position belt. Belt should be aligned with the puncture site equally across both hips. Step 2, center the dome and adjust the belt. Okay. Dome should be centered over the arterial puncture site above the slightly toward the midline of the skin incision. So if you have, like, let's say this is our hip and the artery's down here, the artery goes like this, and when they're accessing it, they access like down here. So in the skin, it looks like it's here, but really the actual incision of the arteries more proximal to the incision site. So that's what it just said, and I'm just repeating it for my own brain in case you aren't realizing. The sheath valves should be, okay, where am I at? Step 2, center the dome, did that. Dome should be centered arterial puncture site above and slightly toward the midline of the skin incision. Yeah. The sheath valve should be below the rim of the pressure dome. Attach the belt to ensure a snug fit. The center arch bar should be perpendicular to the body. Step 3, connect the dome pressure pump. Step 4, for a venous sheath, inflate the dome 20-30 millimeters of mercury and remove the sheath. To minimize formation of AV fistula, obtain arterial hemostasis before the venous sheath is removed. If the arterial sheath, pressurize the dome to 60 and 80, between 60 and 80. Remove the sheath and increase the pressure into the dome to 10 to 20 above the systolic pressure. That's what it is. So 10 to 20 above the systolic pressure. That's what I remember. Maintain full compression for 3 minutes. Then reduce pressure in the dome by 10 to 20 millimeters of mercury every few minutes until 0 millimeters is reached. Check arterial pulse, observe for bleeding. After hemostasis is obtained, remove hem from the stop and rest wound. Okay, arterial closure devices. Okay, so several different types of venous closure devices are currently, vascular closure devices are currently available. They're called VCDs, vascular closure devices. All VCDs have demonstrated rapid hemostasis and a decrease in time to ambulation when compared to manual compression. This is what we use. But none have been shown to decrease vascular complications in randomized controlled trials. These devices may be especially helpful in patients who have back pain or cannot lie flat. Active closure methods include suture type, pre-close, Abbott vascular, extravascular collagen implant, that's what we do, and surgical staple clip technology. Angioseal, that's what we do. Angioseal theoretically has a higher risk of thromboembolic events because of the intravascular collagen anchor. That's what we do. The suture-mediated device used primarily healing end-to-end anastomosis at the arteriotomy site, but have the highest rate of device and operator failure due to the learning curve associated with their use. So we use angioseals. Yeah, and the angioseal is like a collagen plug. And I haven't had any thromboembolic events, but of course I don't know. Because VCDs do not ensure freedom from bleeding or vascular complications, diligent monitoring is still essential, absolutely. The advantages and disadvantages of the various arterial closure devices are summarized in Table 2.2. Vascular closure devices. Okay, we're not going to go over all this. I can't even read it, so we'll skip it. All VCDs should be used with caution in patients with peripheral vascular disease or with a high above upper third of the femoral head or lower at below the femoral bifurcation arterial puncture. So they always puncture over the femoral head. Caution is also needed in patients with scar tissue at the site of prior femoral artery procedures. Oh man, dude, I didn't know a lot of this stuff, and I manage these patients all the time, so it's a little scary. Femoral angiography with an ipsilateral oblique angle, i.e. right anterior oblique RAO of the right femoral artery, left anterior oblique of the left femoral artery lays out the bifurcation, although the sheath entry site is often obscured. On the other hand, the contralateral oblique angle nicely demonstrates the sheath entry site but obscures the bifurcation. The ipsilateral oblique angle is generally preferred, and then the sheath is gently pulled medially, wiggled to determine its entry point. For patients' comfort, femoral angiograms can be done with a 50-50 contrast mixture. Okay, that's fine. Yeah. Okay, we're good with that. Femoral angiograms, anterior-posterior projection, so it's AP projection. The femoral bifurcation is obscured, although the insertion of the sheath can be visualized. Okay, I'm going to look at that again. Yeah, so I can see that. Okay, cool. B, right anterior oblique RAO projection. So let's see that RAO projection. Okay, so there's an RAO projection, and you can see the bifurcation. Oh, okay, so the RAO, you can see the bifurcation. The bifurcation of the femoral artery is now visible. The sheath insertion site is made visible by gently pulling the sheath medially during the angiogram. Okay. Post-catheterization patient instructions and discharge. Okay, this is like my wheelhouse because this is what we do. So Look at this. I'm not lagging at all thus far. I've been streaming for a freaking 10 minutes now. How long have I been streaming for? Let me see this. 20 minutes, dude. 20 minutes. No lag. Maybe because it's a Monday night and nobody's on their internet right now. I don't know. I don't know what it is. But I'm not lagging, so I'm happy. Post-catheterization patient instructions and discharge. Depending on the catheter and sheath size and whether or not the VCD was used, the patient is kept in bed for 2 to 4 hours after femoral artery puncture. Okay, for us, it's 4 hours minimum. And if you had interventions like sheath, you had any kind of PCTI or you had any kind of stent placement, it's minimum 6 hours. We are very careful. In the recovery area, the patient is instructed to 1. Keep head down. Absolutely. 2. Hold the groin site when coughing. Yes. Keep the punctured leg straight. Yes. Stay in bed. Yes. Drink fluids. Yes. Call a nurse for assistance if they see any bleeding, leg numbness, leg pain, or chest pain. Follow bed rest. The patient, let's see. Following bed rest. Oh, this dog. This freaking dog. He wants to play. I need to study. So, following the bed rest, the patient can sit up in bed for 30 minutes and then can walk with nursing assistance. At this point, the groin is rechecked, and if there is no sign of hematoma or bleeding, the discharge process can continue. Percutaneous brachial artery approach. Okay, cool. So, well, let me check on my baby. Time out. Kens? Okay, here we go. Hey, puppy. How you good boy? How you good big boy? How you big boy? Hi. You can't do it. You can't see him. You can't see him. Yeah. Okay. You want to play? Oh, you want to play? Okay. I'm going to chew on this. We'll play tug of war while I read. The percutaneous brachial artery entry, which replaces the brachial artery cut down, should be reserved for patients in whom neither the radial nor femoral artery can be used for access. Although similar to femoral artery puncture, there are several important differences. Let me just guess. Okay, no, I won't guess. I'm just going to read it. The brachial artery is smaller, 3 to 5 millimeters in diameter, than the femoral artery. Because of this relatively loose subcutaneous tissue, the course of the brachial artery may change considerably. Spasm can occur easily with considerable decrease in pulse amplitude, making the puncture more difficult. The artery is more mobile than the femoral artery. Care should be taken to puncture the artery successfully on the first attempt because of the smaller space in the arm. Uncontrolled hematoma formation here can readily cause compartment syndrome with ischemia of the forearm and hand. The median nerve lies immediately medial to the artery. See, that's what's so scary. Accidental touching of the medial nerve causes a peculiar electrical shock sensation in the hand. Oh, how funny. Oh, don't mind that electrical shock sensation. It's just me poking your brachial nerve with a needle. Yeah, not cool. The operator should check the brachial and radial pulses before attempting brachial arterial puncture. Both pulses should be strong and equal in both arms. In patients in whom femoral access is not possible because of severe atherosclerosis, vascular surgery, or the presence of an intra-aortic balloon pump or LV support device, same type of atherosclerotic disease may exist in the subclavian arterial system. Scary. Subclavian axillary artery system should be auscultated carefully for bruits above and below the clavicle. Anesthesia administration. The maximum point of brachial artery pulse is located approximately 1 centimeter above the elbow crease. So 1 centimeter maximum point of brachial artery pulse. Really? Oh, where am I going to find it? Let's see. Above the elbow crease. Okay, I definitely feel that one. Maximum point of brachial artery pulse located approximately 1 centimeter above the elbow crease. That's, oh yeah, I feel a big one. With a 25 gauge needle, infiltrate the skin of subcutaneous tissue with 2 to 3 ml of 1% lidocaine. Inject the excessive amounts. Local anesthetic may make palpation of the artery difficult or obscure the pulse completely. Puncture of the artery and introduction of the guide wire. Okay, here we go. And just so we know, just for clarification, why am I reading all this stuff? For one, super interesting to me, and two, eventually, Lord willing, I'm going to be able to scrub in and help the docs with these access points. So, running the guide wire, pulling the needle, and getting the catheter all set up. All right, here we go. Similar to the radial artery entry technique, a micropuncture needle with a 0.18-inch guide wire is used to enter the brachial artery. The through-and-through puncture with an angiocath needle is not recommended in this location. To facilitate the arterial puncture, the operator can stabilize the artery with the index and middle finger placed below and above the puncture point. After seeing brisk bleeding from the needle, the guide wire is advanced into the artery and the sheath is placed in, as with radial. What's this? My phone's freaking out. Placed with radial artery cannulation. Additional lidocaine can be applied to the deeper tissue planes. You want to go outside, puppy? You want to play? Where's your toy? Where's your toy? Okay. Okay. Sorry. Let me see something real quick. Okay. Okay, hemostasis, percutaneous brachial artery catheterization. Okay, got past that. Anesthesia, puncture artery. Okay, through and through, got that. Facilitate artery puncture. The operator can stabilize. Got that. Fingers below and above the puncture. After seeing brisk bleeding from the needle, the guide wire is advanced into the artery, and the sheath is placed. As with radial artery cannulation, additional lidocaine can be applied for deeper tissue planes. Heparin 40 to 50 units per kilo is given via IV. The brachial artery can accommodate up to a size 8 French sheath in larger males. In most patients, especially smaller females, smaller sheaths, for example a 6 French, are preferred. Hemostasis after percutaneous brachial artery catheterization. A board is placed behind the patient's elbow to facilitate pressure application. Check the radial pulse before removing the sheath. If the pulse is weak or absent, 0.2 to 0.4 milligrams of nitroglycerin can be delivered into the artery through the sheath, and then the pulse should be rechecked. Remove the sheath while applying firm finger pressure over the puncture site. A small amount of bleeding is allowed to purge possible clots. The operator should not strip the sheath, pushing thrombus into the artery. Continuously palpate the radial pulse either with manual palpation or that's a fun word, plethysmography. Hold on. Plethysmography. Okay, there's a funny word. Let's look that one up really quick. If I don't know a word, I'm going to check what the word is. I'm just going to read past a word I don't know. That wouldn't make any sense. So let's just type it in. Here we go. Plethysmograph. Plethysmograph. A plethysmograph is an instrument for measuring a change in volume within an organ or whole body. The word is derived from the Greek plethysmos and graphos. Plethysmograph. Purpose. Okay. Okay, so it's just like pressure compartment readings. Okay, and adjust the amount of pressure applied over the artery to stop bleeding without completely obliterating the radial pulse. After 15 to 20 minutes, slowly release the pressure. Check and record the patient's radial pulse. The arm circumference and the site of the puncture can be measured to facilitate detection of hematoma formation. Instruct the patient to keep the arm in a relaxed but straight position for 2 to 4 hours. Oh, geez. Sitting up in bed is permitted, but ambulation is restricted after use of hemostasis period of 2 to 4 hours. Okay, other vascular access. Access to the patient's circulatory system is not limited to the previously mentioned techniques. Techniques that are used rarely in the catheterization laboratory, such as axillary artery puncture, should be attempted only by experienced operators. Percutaneous subclavian vein puncture techniques are not explained here because they are not used for routine cardiac catheterization. So if we're going to place a subclavian central line, if you're going to place a sheath in your subclavian, you're basically just putting in a central line. Arterial, radial, femoral, brachial, least desirable, and axillary. Venous would be brachial, femoral, interjugular, subclavian. So IJs and subclavians are going to be just central lines basically. And if we're going to be like, let's say we're intubating the patient, they've lost their hemodynamics, like their maps are dropping or their whatever it may be, anesthesia may intubate them, put them on a vent, and then place a subclavian line so that I can start running multiple pressures if I need to. or I can run fluids and pressures or whatever it is. So if I can get like a triple lumen, 6 French sheath catheter in his subclavian, then I can run a bunch of crap through it and keep his blood pressure or her blood pressure up. So that's really probably what the IJ or the subclavian's for. IJ vein access. Okay, I love IJ vein access. Here we go. The internal jugular vein is lateral to the carotid. So here's the carotid. It's going to be lateral. So let's see if I can vagal down and see if I can see my... There it is. That's the external jugular. So internal jugular is going to be probably right. I can't really see. It's all reversed. Anyways, okay, so it doesn't matter. That's the EJ. So that's EJ. That's an EJ. That's an EJ. So, okay. Internal jugular vein is lateral to the carotid artery, medial to the external jugular vein. So medial to the external jugular vein. So it's like, keep going on the wrong side. So there's my artery here. There's my carotid. There's your carotid. So lateral to there. So it's somewhere in here. It's probably somewhere here. I'm not gonna feel a pulse. I don't know. So okay, let's keep going. The internal jugular vein is lateral to the carotid artery, medial to the external jugular vein, and usually just lateral to the outer edge of the medial head of the sternocleidomastoid. So outer edge of the medial head of the sternocleidomastoid. So sternocleidomastoid, so medial head. So it's going to be right on in here. Right here. Somewhere right on in here. So I can't feel a pulse. So it's probably right here. Here's the medial head. The sternocleido. There's my sternocleidomastoid, right? Sternocleidomastoid. Medial to the sternocleidomastoid. So like right here. That might be it right there. Alright. Okay. To identify landmarks, so let's read that again. Usually just lateral to the outer edge of the medial head of the sternocleidomastoid muscle. To identify landmarks, the operator instructs the patient to lie supine without a pillow under the head, and in the case of the right internal jugular, with the head turned 30 degrees to the left. Patient with low venous pressures may be placed in a Trendelenburg position. Ultrasound imaging to facilitate access is recommended by the critical care societies. Yeah, several. I'm just. You know what? Let me just blind stick. You know what? Yeah, no, you're about there. You're about there. Let's go for it. Yeah. No, don't even sit back. No, just sit there. You're good. Yeah, we're gonna go for it. Ooh, yeah. So it's like that's probably it right there. That's probably it. You just follow it right up. And you can do it higher, right? You can do it higher, probably somewhere here. But there's a lot of vascular in here. It's scary. Oh, jeez. Okay. Let's keep reading. Okay, identify blah 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 with the head through blah blah blah. Okay, ultrasound imaging. Okay, several approaches to internal jugular vein access exist. Many physicians and the critical care societies recommend the use of ultrasound to guide access. I totally agree. A higher anterior approach from the top of the triangle formed by the two heads of the sternocleidomastoid muscle and the clavicle is recommended. Absolutely. This location moves the puncture site away from the upper lung tip. In obese patients, the triangle can be difficult to localize correctly, but it is helpful to put a finger in the substernal recess and move the fingers to the right for a right internal jugular access. The first evaluation palpated in the medial head of the sternocleidomastoid muscle. The first elevation palpated in the medial head of is the medial head of the sternocleidomastoid muscle. Move the fingers over the medial head and allow the edge superiorly, and follow the edge superiorly until the top of the triangle is palpated. Okay, so let's do that right now. So right. So here's the right. So you have them turn their head 30 degrees. We can feel that. This is the medial head of the sternocleidomastoid, right? Just under the sternum. We're going to pass that. We're going to keep going other way. We're going to keep going other way right here. So we can feel this soft, pushy, and so we'll just follow this right up the triangle. There's a triangle. See that triangle? Look at that. That's a perfect triangle right there. Right here. That's the triangle right there. So you fall all the way to the top, and that's where we're puncturing right there. That's going to be the internal jugular right there. Look at this. We are just learning so much. I wish I had a little 18 gauge. I could be like, okay, here we go. And pop. Just kidding. Not going to do that. All right, here we go. Okay, after infiltrating the skin a little, okay, this location moves a little, okay, correctly, but okay, here we go. Where am I? This location moves the puncture site away from the upper lung. Okay, I got that. Obese patient. First elevation, okay, got that. Move the fingers over the medial head and follow the edge superiorly until the top of the triangle is palpated. Got that. After infiltration of the skin with lidocaine, insert a needle through the skin, pointing slightly toward the ipsilateral nipple. When blood is aspirated, the guide wire is inserted, followed by the sheath using a standard Schlesinger technique. The external jugular vein, which crosses the same area superficially, should not be cut. Vascular access through synthetic graft conduits. Oh, damn. Now we're really getting into it. If possible, avoid this. Avoid access through synthetic peripheral vascular grafts. Yeah. Limited experience indicates that when grafts are at least 6 months old, complications are less than 2% if 5 to 9 French sheets are used for diagnostic but not interventional procedures. If it is necessary to use grafts to access, diligent care must be taken during hemostasis as to not occlude the graft completely, which can lead to graft thrombosis. Oh, goodness. Large bore access. Yeah, no, that's what I'm talking about. All right, now I'm down for some large bore access up in here. Large bore access for valvular heart procedures introduces an increased risk for bleeding and vascular complications. Although many aortic balloon valvuloplasty procedures can be done through a 12 French arterial system, the current era of transcatheter aortic valve replacement (TAVRs) is increased the necessary sheath size for access to 18 French for the Medtronic core valve system, or 24 French for the Edwards Sapien system. Oh my gosh, 24 French. The use of these large bore sheaths necessitate thoughtful attention to procedural planning and post-procedural hemostasis. Many operators will also access the contralateral artery to visualize the side to be used for the femoral artery. Initially, the crossover to the ipsilateral femoral with a guide wire and exchange for a pigtail catheter. Okay. After injecting contrast through the pigtail catheter, the assuring absence of valvular disease in proper access site and vessel size. Although this is initially done via the pre-procedural CT scan, access is obtained for the large bore sheath, often usually the center of the pigtail catheters as the needle target. The pigtail catheter is then exchanged over an 0.35-inch guide wire that remains in place during the procedure. Following TAVR to control bleeding during CVD placement, deployment of a peripheral balloon large enough to occlude the iliac artery is advanced over the contralateral guide wire proximal to the anterior arteriotomy site and inflated temporarily, stopping blood flow down the vessel. It is in this bloodless field that post-procedural hemostasis is undertaken. Okay, so I don't think we do TAVRs, and I would think that'd be super cool to do TAVRs. But I don't think we do TAVRs in my cath lab because we don't have cardiac surgery here. So if stuff goes bad, they have to ship them. They're like, oh, oops, gotta go. Send them. Send the pictures. All right. Now send the patient. All right, let's see. Okay, most commonly used devices for hemostasis in the setting of the Perclose. Are they good? Yeah. Okay. Should I stop reading? All right. Most commonly used device for hemostasis in this setting is the Perclose ProGlide SMC system from Abbott, using a pre-close technique. The pre-close technique uses two devices placed after initial arterial access is achieved. The first device is deployed, oriented slightly off the vertical at the 10 o'clock position. Use standard placement technique, but the suture knots are not tightened down on the arteriotomy, but rather clamped and placed under a sterile towel to be closed at the end of the procedure. Second device is deployed oriented at the 2 o'clock position relative to vertical. After the second device is deployed and in a fashion similar to the first device, the sutures are set aside to be tied later. At this point, reintroduce a guide wire through the port of the VCD and exchange it for the large bore sheath ready to proceed with the main procedure. Okay, let's see this. Okay. First device, second device, third device potentially needed. Holy moly. Pre-close technique signifies that the pre-close proglide suture is placed around the arteriotomy at the beginning of the procedure, and not advancement is placed on hold until the procedure is complete. The pre-close technique using at least 2 devices must be used when closing sheath sizes from 8.5 to 21 French. See the text for more information. Holy moly. Okay, so that's definitely out of my wheelhouse. I don't think we do TAVRs. After completing the main procedure, hemostasis begins. Place the guide wire through the large bore sheath. The contralateral balloon catheter is now placed in the ipsilateral iliac artery and inflated to stop blood flow. Aspirate and flush the sheath and tighten the first sutures placed, but not yet secure the sutures on the arteriotomy site while the sheath is being removed with the guide wire position maintained. Second set of pre-closed sutures is then simultaneously tightened at the arteriotomy site. Deflate the occlusion balloon. The site is now assessed for relative hemostasis. There may be some slight bleeding, but it should not be pulsatile. This is repeatedly checked during these steps by deflating the iliac balloon and assessing. If significant bleeding is identified, advance the first suture set knot and then subsequent suture knots until bleeding is minimized. Complete hemostasis is unlikely with the guide wire in place, but if significant bleeding continues, the third VCD can be deployed at 12 o'clock. Once bleeding is controlled, the guide wire can be removed and the first and then subsequent suture tightened on the arteriotomy. Lastly, the sutures should be held taut and recut in the order in which they were deployed. The balloon in the iliac artery can then be deflated. If full hemostasis is achieved, perform a final angiogram to assess vascular integrity. Having the balloon in place during the deployment of the pre-closed device provides an additional measure of safety should the closure not hold and additional procedures become necessary to provide hemostasis. Okay, so here is a picture. Too bad I can't show you guys a picture. I don't know how to do that. I'm not skilled enough for that. Boom, boom. Okay, I see. Okay, very cool. All right. Oh my goodness, look at that. That's nuts. Tips and tricks. Options to achieve success. Save time. Do it right the first time. A thoughtful and systemic approach to the catheterization procedure decreases problems of access. The order of arterial and venous access is often a matter of personal preference. For novice operators whose stereotactic view through their fingers needed refinement, attempts at femoral venous entry before arterial sheath insertion are recommended for the following reasons. If the arterial sheath is inserted first, firm palpation to establish the landmarks for venous entry may cause the formation of a generous hematoma that may crimp the arterial sheath. This rapidly forming hematoma makes venous location more difficult. If the artery is punctured inadvertently during venous access attempts, the arterial sheath can be inserted as long as the precautions described in the section on the percutaneous femoral approach are observed. Vessel tortuosity. The most commonly encountered difficulty in advancing guide wires or catheters into the aorta is iliac or subclavian vessel tortuosity, a condition often found in elderly patients. A 0.35-inch Woolley or hydrophilic glide wire have excellent characteristics, flexibility, and an atraumatic steerable tip. In cases of extreme tortuosity, it might be necessary to advance a catheter close to within several centimeters of the guide wire tip in order to increase the torque control of the guide wire. A JR or a MP multi-purpose coronary catheter, okay, so a Judkins right, so a JR, so a JR4, JL4, and which is Judkins right, Judkins left, and then there's a AL1, AR1. So a JL4 or an MP multi-purpose coronary catheter can also be used to change the direction of the guide wire tip. In patients with tortuous iliac vessels, a long, greater than 20 centimeter sheath may be used. Recognizing the trade-off of multiple friction points for some straightening of the vessel. Catheter exchanges over a long 300 centimeter stiff exchange guide wire may be required to avoid undue prolongation of the procedure by repeated attempts at advanced catheters across tortuous atherosclerotic segments. In patients with extreme tortuosity in the iliac or subclavian system, the torque control of a catheter is markedly decreased. Perhaps pre-shaped catheters rather than MP catheters are preferred in these cases because less manipulation is required to engage coronary arteries. In addition, advancing a pigtail catheter into a left ventricle of these patients may be difficult and involve loss of catheter length and control across tortuous segments. Problems with catheter engagement may be partially overcome by keeping an 0.35-inch J-tip guide wire in the catheter after advancing the catheter to the central aorta and manipulating the catheter with the wire in place to engage coronary arteries. In some cases, an extra stiff Amplatz type guide wire can straighten tortuous veins, but vessel folding and kinking at the curves may cause pain. In the upper extremities, trauma with extra stiff guide wires is also a concern. A deep breath, as already mentioned, can dramatically ease difficulties of catheter passage to the central aorta when a catheter is coming from a radial artery. Remember, wire contact with blood forms thrombi despite anticoagulation. Jeez. Limit wire-loaded catheter manipulations to 2 to 3 minutes, maintaining adequate ACT, and use meticulous wire wipe and sheath flush techniques. Oh gosh, so I got to learn wire wipe and sheath flush techniques. I did not know wire wipe and sheath flush techniques. Complications of arterial access. Here we go. So I'm talking about. This is a nitty gritty right here. I might need to take a break. How long have I been going at this? So, dang, dude, I did 45 minutes. So usually I'll do like 15 to 30 minutes, and then I'll stop and take a break and let my brain cool down because right now I'm processing a lot. So I don't know if I should keep going. Naturally, if I was by myself, I probably wouldn't keep going. I'd take at least a 15-minute break right now because my brain, I'm going to be honest, my brain's on overload with all this. This is a lot of information coming at me. I mean, it's definitely processing and it's definitely clicking. So things are clicking really well. But I can feel my brain making new neural pathways with all this information. Like I can feel it working. Most common complications are, I'm just keep going, I don't care. And I'm drinking sleepy time tea with valerian root, so now I'm really working hard, making my brain work harder than I'm wanting to slow down. So that's always kind of fun. So complications. So how far do I want to get? How far am I into this thing? Let me see here. So I'm 19% into this book. I'm going to get to, let's just keep going and see what happens. The most common complication of femoral cardiac catheterization is local hematoma formation. Other common complications in order to decrease frequency include retroperitoneal hematoma, pseudoaneurysm, AV fistula formation, arterial thrombosis, secondary intimal dissection, stroke, sepsis with or without abscess formation, and cholesterol or air embolization. The frequency of these complications is increased in females and elderly, those with renal failure and peripheral artery disease, those undergoing high-risk procedures, and those receiving anticoagulation, antiplatelet, and fibrinolytic therapies, which is basically everyone getting a cath. In addition, although there is an increased risk in the morbidly obese, patients with a small body mass index are actually at the higher risk. Small women, particularly those with a high puncture above the upper third of the femoral head, are at greater risk for retroperitoneal hematoma. A retroperitoneal hematoma is the diagnosis in patients with hypotension, tachycardia, and pallor, a rapidly falling post-catheterization hematocrit, lower abdominal or back pain, or neurologic changes in the leg in which the puncture is made. Pseudoaneurysm presents as a painful palpable mass and is associated with a low puncture, usually below the femoral head. In the past, all femoral pseudoaneurysms were routinely repaired by the vascular surgeon to avoid further neurovascular complications or rupture. With ultrasound and imaging techniques, these false channels can be easily identified and non-surgical closure pursued. Manual compression of the expensile growing mass, guided by Doppler ultrasound with or without thrombin or collagen injection, is an acceptable therapy for femoral pseudoaneurysm. Okay, so skin, clamp, so here's a picture. I'm just looking at a picture of the clamp, the clot. So non-invasive technique for closure of a femoral artery pseudoaneurysm by external compression. Okay. closure and direct blood flow, direction of blood flow. Okay. Blood is shown flowing from the common femoral artery into a large pseudoaneurysm through a large tract. External application of pressure using a vascular clamp guided by Doppler ultrasound color flow probe results in obliteration of the tract and clot formation of the pseudoaneurysm. Okay, cool. Okay, AV fistula formation is also associated with a low puncture. Okay, most common undetected, but most go undetected. But if the formation is large enough, patients can experience pain and swelling in the lower extremity. Very large AV fistula can lead to high output heart failure. Jeez. In such cases, a stent graft or vascular surgery may be required. Infections are more common in patients who undergo repeated ipsilateral femoral puncture or prolonged femoral sheath maintenance within 1 to 5 days. Cholesterol embolism manifestations with abdominal pain or headache from mesenteric or central venous system ischemia, skin mottling, renal insufficiency, or lung hemorrhage may be a clinical finding in 30% of high-risk patients. Geez. Compared with the femoral approach, the brachial but not radial approach has a higher risk of bleeding and vascular complications. On the other hand, such complications are rare when the transradial approach is used. A bleeding complication in a radial case can easily be recognized and controlled, as discussed earlier. The Bleeding Academic Research Consortium has published new bleeding definitions in an attempt to standardize such definitions among clinical trials. With this scoring system, it is hoped that one would be able to compare results from one clinical trial to another. Access and hemostasis, nurse technician viewpoint. Oh yeah, that's what I'm talking about. So this is like my wheelhouse. So this is really what I've been doing. Sorry, give me a sec. Time out. Break. Oh yeah. All right. Here we go. Almost. Okay, here we go. Access and hemostasis, the nurse technician viewpoint. The nursing and technical staff play an integral role in obtaining safe and successful arterial and venous access and hemostasis. Their knowledge of anatomy, patient positioning, and equipment is essential to providing optimal patient care and support during all phases of the cardiac catheterization procedure. Pre-cath assessment. Any procedure may be complicated by an inherent vascular trauma associated with bleeding. Therefore, planning ahead is important. For the procedure, a staff member should describe to the patient the sensations that he or she might experience while the physician is obtaining vascular access. On the patient's arrival to the cardiac catheterization laboratory, the nursing and technical staff must 1. Assess the patient's baseline peripheral vascular status, including an Allen or Bobo test for radial procedures, position the patient properly on the procedure table for a femoral radial approach, and prepare the access site in the manner that facilitates vascular access by the physician. Alternative access sites may also need to be prepped in advance for unanticipated entry problems. All pulses should be palpated, or when necessary, Doppler assessment should be performed. Information concerning presence and stability of the pulse must be conveyed to the physician. Even the uninvolved lower extremity may lose pulse from a central embolus or dissection. Okay, good to know. Baseline vascular assessment. The patient's procedure or pre-procedure peripheral vascular status, i.e. pulse quality, should be assessed and documented on the catheterization chart before the start of the procedure. In some laboratories, assessment is the responsibility of the nurse, whereas in other laboratories, all personnel share this duty. It is a good idea for the person responsible for post-catheterization care to perform the initial assessment so that any changes in vascular status can be recognized easily. Many laboratories are set up so that the same staff member managing the patient entry and pre-preparation and recovery areas. This setup is ideal because the staff member responsible for the pre-catheterization assessment and post-catheterization care can easily assess any changes in the patient's baseline status. And that's kind of what we do at the hospital. If I have somebody coming in, they're going to get a cath, I'm going to make sure they're pre-op. So what's a pre-op? They're going to have their consents are going to be signed after the doctor talks to them. We're going to mark their pedal pulses. We're going to do a we'll make sure they have the right IVs. So like 2 IVs in the left with a minimum of a 20 gauge. And then we'll get baseline vitals and check their allergies, MPO status. Might check their pro time INR, kidney function, and then if they're insulin diabetic, make sure they're on NPH. We would note that, and then we would probably a lot of times we'll hold their anticoagulants. So if they have aspirin or heparin due, we'll hold those usually. Okay, let's see. Many laboratories are set up so that the same staff will in the radial arterial approach is used. The pre-catheterization assessment of the radial and ulnar pulses must be performed. Mark the location and document the grade on the chart. If the femoral approach is used, the femoral artery, dorsalis pedis artery, top of the foot, and posterior tibial artery inside behind the ankle pulses should be assessed, graded, and recorded on a scale of 0 to +4, 4 being maximal or a bounding pulse. It is helpful to use a marking pen, that's what we do, to indicate the location and grade of the pulse on the patient's foot to facilitate post-catheterization assessment. Patient positioning, radial artery approach. For radial artery approach, the arm can be positioned on the arm board to stabilize the position of the wrist, or the arm may be placed next to the body on a pillow in an arm cradle. Most X-ray tables have accessory arm boards that mount on the side of the X-ray table. Proper orientation of the radial artery occurs if the arm is placed with the hand secured in the palm up position and the wrist is hyperflexed with a small pad underneath it. Place the drape so that it exposes only the area targeted for access. Because the physician will be going 2 centimeters proximal to the bony prominence of the distal radius, the distal edge of the drape hole can start there, leaving more of the form exposed and available for access. After obtaining a vascular access, bring the arm to the patient's side near the femoral artery. If an arm board is used, the catheter insertion and manipulation can proceed as with femoral access. Okay, looks good. Patient wrist straight radial procedures. The hole is placed so that the most distal end is at the bony province of the distal radius. A full sterile radial drape is placed prior to the arm being moved to the right hip for catheter insertion. Femoral approach. Proper positioning of the patient of the catheter on the catheterization table for laboratory personnel is important to facilitate arterial and venous access. For the femoral approach, the patient should be in the supine position. In some laboratories, the patient's arms are placed behind the head, ensuring that the hands and arms are away from the sterile drape and while not being in the way of the C-arm in the X-ray unit. However, the problem with placement of the arms above and behind the head is that the patient will likely become uncomfortable, and fatigued, during a long procedure. And it kinks if you've got an AC. If you got a 20 AC and their arms like this, you're going to kink your AC too. That's not good. Positioning the arm the patient's side is the most common method. Instruct patients to keep their arms as close to the body as possible and under the sterile drape at all times. Instructing patients to tuck their hands under their hips may help remind them to keep their arms at the sides and aid in remaining a comfortable position during the procedure. Positioning the patient's arms at the sides causes the arms to appear in the X-ray field and compromises angiography performed in severe oblique angles projections. For a lateral projection, arms should be raised and placed behind the head. Position patients with their legs spread slightly so that their knees are 8 to 12 inches apart. This position facilitates access to the groin by pulling the skin folds apart at the inguinal crease and creates a space on the catheterization table to hold equipment, syringes, gauze, and so forth. Position the patient so far toward the head of the catheterization table as possible. This positioning allows travel of the C-arm to recover the inguinal area and fluoroscopic landmarks, femoral head, for example, the femoral head. If access is difficult because of vessel obstruction or tortuosity, it may be necessary to use the fluoroscope over the insertion site. If the patient is positioned too far toward the foot of the X-ray table, fluoroscopic visualization of the area may be impossible. The obese patient for the femoral approach. Obese patients present a challenge to the staff in terms of positioning and site preparation. The operator should consider a radial approach first. If proceeding with femoral access, the first problem usually encountered is that most catheterization tables are narrow, which leaves no room for comfortable positioning of the patient's arms. A plexiglass arm retainer gives some support and helps keep the patient's arms at his or her side. That's what we use. Positioning the arms above the head for short procedures is recommended for obese patients. The second challenge is at the groin preparation. The protruding abdomen and panniculus of the obese patient usually extends and rests over the groin area, presenting an obstacle to access and preparation. The abdomen wall can be retracted toward the chest and retained in this position by using 3 to 4 inch wide tape. Nice. I'm not going to go there. The tape can be crisscrossed, over the retracted abdomen and secured to the side of the catheterization table. Yep, been there, done that. When the abdominal folds are retracted, the groin can be prepared in the usual fashion because excessive skin folds in the obese patient may result in higher than normal amounts of skin bacteria. Extra care should be taken when cleaning the skin and applying antiseptic solutions. Position the morbidly obese patient for the radial approach. Need some water. I drank all my tea. Morbidly obese patients may exceed standard weight limits on catheterization tables. Some manufacturers indicate that the highest current weight recommended is 220 kilo. Placing a patient who is larger than the table weight limit makes the procedure difficult for both the patient and the laboratory staff. Catheterization tables are built on efficiency, not comfort. Some tables measure as little as 18 inches wide and are thus unable to accommodate the larger width of an obese patient. Panning, angulation, X-ray penetration, and performing cardiopulmonary resuscitation are all compromised in this setting. You betcha. Dr. Kimberly A. Skelding of the Ginzinger Clinic recommends using the following patient placement approach, in which the patients are safely catheterized regardless of their weight through a radial approach. Here are the setup steps. Place the patient on the stretcher instead of the hospital bed. Wheel the stretcher to the left side of the catheterization table. The head of the stretcher should be at the shoulder area of the catheterization table, with the stretcher and catheterization table facing perpendicular to each other. 3. Ensure that both beds are locked and attached. A support board under the X-ray mattress and under the top of the stretcher mattress. This helps allow the bed to move together and support the patient. The patient then moves himself or herself, with help from staff if necessary, north toward his or her head so that the patient resides half on the catheterization table and half on the stretcher. This allows the arm to fall at the center of the catheterization table. Interesting. Oh, okay, I see. Can't connect to this network. What? Okay, I'm there now. Back in it. Let me look at the chat. Please try again. Am I on? I think I'm on. Back in it. My internet just freaked out. My internet had a little hiccup. How long have I been going? Look at that. I got an hour in. It's pretty good. I think I'm on. All right, let's keep going. Let's do it. Equipment used for access. RAOs. Cranial. Still a teenager. What are we talking about? Okay, so patient. Okay, go to that. Equipment used for access. A variety of needles, guide wires, and vessel dilators and interdigital sheaths are available for use in obtaining vascular access. Because of components necessary for access come in many different sizes, staff members must be knowledgeable regarding compatibility of the different components. Certain needles accept only certain size guide wires. The same is true for compatibility among wires, catheters, and interdigital sheaths. This is where it gets very complicated. Components component package inserts containing information regarding size and component compatibility. The catheterization team members should understand the anatomy of the vascular system for access and catheter placement depending on the clinical presentation when the patient needs a right-sided, left-sided, or combined right-left-sided heart catheterization procedure. Post-procedure assessment. Hold on a second. Okay. Prior to arriving in recovery, it is important that the nurse taking the patient understands what happened during the procedure. He or she should know what procedure was performed, access used, the drugs given, whether there were any complications during the procedure. In addition, knowing the patient's mental status and vital signs during the procedure will help in determining if anything has changed once in recovery. If radial access was used, the patient should arrive in recovery with a hemostatic wristband in place. One of the first important steps after establishing that the patient is hemodynamically stable is assessing for patent hemostasis with the device on the wrist and the pulse oximetry with plethysmography on the ipsilateral thumb. The nurse occludes the ulnar artery to determine the Barbeau test. If it is a Barbeau D, the nurse attempts to let some of the air out while maintaining hemostasis. If unsuccessful, another attempt should be made in 15 minutes and every 15 minutes thereafter until there is a Barbeau A, B, or C indicated that the patient hemostasis has been achieved. Once patient hemostasis is achieved, it should be confirmed once in an hour. If the nurse is unsuccessful in achieving a patient hemostasis by the time the device is to be removed, the physician should be notified. Protocols vary, but patients who have had a radial procedure can be immediately ambulatory as long as they are safe to do so from a hemodynamic and neurologic perspective. In labs that are accustomed to femoral access, it can be challenging mental transition for the recovery personnel to move from a patient on a strict bed rest to up ad lib. Still, this is one of the benefits of the radial procedure. And adjusting the new paradigm is more than worth the effort. There is a significant reduction in the nursing load when patients can sit up and engage in activities and ambulate to the restroom on their own. Absolutely. In addition, one of the main complaints from patients with regard to their cardiac catheterization is not the procedure itself, but the time afterwards, when they have to lie flat for hours and have someone pushing on their groin. Walking early after the procedure increases patient satisfaction and also hastens recovery, so the patients leave the hospital sooner. This, in turn, has been shown to reduce medical costs. Safe and effective vascular access and hemostasis are key components to an overall successful cardiac catheterization procedure. Key steps must be followed throughout the entire process from procedure to recovery to make this happen, and it clearly takes the cooperative effort of the whole team. In addition, a new technique continues to be introduced, such as radial and large bore access. The entire catheterization lab must have a method of quickly educating the staff and seamlessly adapting to change. For more information, see videos 2.1, 2.2, and 2.3. Oh, we get videos? Suggested readings. All right, we're not going to read this right now. Okay, so I think I finished the first chapter. Yeah, or 2 chapters. Finished 2 chapters. Coronary angiography and ventriculography. Oh, I've made it. Now we're getting into the nitty-gritty. The leading cause of death worldwide is coronary artery disease. And the gold standard for the diagnosis of coronary artery disease is catheter-based coronary angiography. The risks and limitations of this technique must be noted, regarding the angiographer to be ever vigilant. From pre-procedure assessment to the acquisition of images to the post-procedure follow-up, care must be taken at each step to maximize high-quality data collection with minimal patient risk and discomfort. Angiographic data derived from the coronary, ventricular, and peripheral vascular imaging are the most significant products for cardiac catheterization, and these assessments all often yield the most critical information for patients with cardiac disease. Optimal angiographic imaging is the result of a series of linked steps. Failure of any link breaks the imaging chain and may cause loss of all or part of the data. The chain begins with the position of the patient on the table, followed by vascular access, catheter placement, correct positioning of the patient on the table, imaging views, contrast injection for acquisition of images, display of the images for review, and finally analysis and archiving of the digital images. The major causes of poor angiograms include factors specific to the patient: size, hardware, angiographic technique, equipment-related problems, and optical and digital imaging system issues. Causes of poor angiograms: size, movement, hardware, anatomic condition, angiographic factors, poor catheter seating, wrong catheter shape or size, anomalous origin, sub-selective cannulation, poor contrast, opacification, weak injection, volume too small, diluted contrast materials. Equipment factors: X-ray generated problems, X-ray tube problems. All right. All catheterization laboratory personnel should recognize the importance of procedure assessment and be aware of indications for why the patient is having a procedure performed. As a measure of quality within the laboratory, appropriate documentation should be provided for each patient to describe the indications for the procedure, and ideally, the operator should reference the indications category from the American College of Cardiology Society of Cardiovascular Angiography and Interventions Appropriate Use Criteria AUC document. In this way, patient indications that fall in the uncertain or inappropriate categories can be addressed before the procedure occurs, for these categories do not address all individual patient level decision making. Thus, it is important to be familiar with the AUC document. Furthermore, the SCAI has developed an application that can be downloaded to smartphones and, after answering a few short questions, can display an indication category for the individual patient, although available through the ACA website. All right, I'm not going to go through that. Patient preparation for coronary angiography. Here we go. Okay, I think, where am I at? Here we go. 21% in. Okay. So I think I'm going to call it for the night. Should I? Hold on. Let's see. Give me a second. You want to go outside? You want to go outside? Okay, hang on a second. You go outside, you got a potty? Okay. Back at it. Here we go. Okay, patient preparation for coronary angiogram. You know what, dude? I feel really good with this because I prep them all the time. And I probably should read this. Let's see. Before proceeding with cardiac catheterization, informed consent must be okay. I'm good with informed consent. Administering conscious sedation should correct forms. Okay, I'm good with that. Medications are part of the catheterization laboratory routine. CAD include aspirin. I'm good with that. Other drugs, blah, 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 blah. Warfarin, continuum of warfarin. Administration of the antiplatelet medication, clopidogrel, ticagrelor. Okay, coronary. Okay, the goal of coronary angiography is to visualize coronary arteries, branches, collaterals, and anomalies with enough detail to make a precise diagnosis and plan for the treatment of CAD. With percutaneous coronary interventions, PCI, stents, the coronary angiographer must demonstrate the precise location of disease relative to major and minor side branches and the associated vascular anomalies, such as thrombi, calcifications, or aneurysms. For the performance of PCI, visualization of vessel bifurcations, vessel tortuosity, origins of side branches, and portion of the vessel proximal to the significant lesion, and the specific lesion characteristics, for example, length, eccentricity, and calcium, is crucial. In the case of a total vessel occlusion, a CTO, a chronic total occlusion, CTO is chronic total occlusion. The distal vessel should be visualized as clearly as possible by opacifying the contralateral coronary arteries and collateral vessel pathways. CTO angiogram requires extended scintigraphy imaging runs that are long enough to visualize late collateral vessel filling with appropriate panning across the heart. The features of the proximal segment, the distal cap, the length of the occluded segment help determine the suitability for CTO revascularization strategy. The routine coronary angiographic views should visualize the origin and course of the three major vessels and their branches in at least two different planes. Because coronary anatomy varies widely, appropriately angiographic projections must be modified for each patient. The choice of catheters for coronary angiography depend on the approach, radial or femoral axis. The physician preference, regardless of approach, the angiographic catheter is advanced over the J-wire to the aortic root under fluoroscopic guidance. Engagement of the left main coronary, LMCA, left main coronary artery, can be performed in anterior-posterior AP or left anterior oblique LAO, whereas engagement of the right coronary, RCA, is performed in LAO. Regardless of the catheter or the artery, coaxial alignment of the catheter with the artery should be obtained by subtle movement of the catheter while carefully observing the catheter tip pressure waveform on the hemodynamic monitor. Before contrast injection through the catheter, operators must pay careful attention to the invasive pressure waveform, either as dampening or showing ventricularization, which may indicate that the catheter is into a small side branch, example a conus, or up against a plaque or left main LM roof, where injection might lead to ventricular fibrillation and or dissection. Oh my gosh. Okay. Care also must be taken to notice deep seating of the catheter, which may lead to an operator to miss an osteal lesion beyond which the catheter has moved. During contrast injection into the coronary tree, the operator should note an adequate reflux of contrast back into the aorta to ensure that an osteal lesion is not present. It is routine in many laboratories to administer intracoronary nitroglycerin to combat catheter-induced spasm that can mimic stenosis. Catheter-induced spasm is typically more common in the RCA. For all catheterization laboratories, the X-ray source is under the table, and the image intensifier is directly above the patient. The source of image intensifier, also known as the flat panel detector, is fully digital in fully digital laboratories. Move in opposite directions in an imaginary circle around the patient who is positioned on the catheter in the center. The body surface of the patient facing the observer determines the specific view. The relationship holds true regardless of whether the patient is supine, standing, or rotation. Okay, anterior view, posterior view, right, left, lateral, left anterior oblique, and right anterior oblique. Okay, I'm good with that. There we go. So it's AP caudal, AP cranial, caudal, cranial, caudal, cranial caudal. And there's RAO, right anterior oblique, LAO, left anterior oblique, caudal, left anterior oblique, cranial. Okay. Nomenclature for radiographic projection, small plaque, arrows, I got all that. Okay. Angiographic nomenclature. Oh man, here we go. Hold on a sec. Time out. Okay. AP, good with that. RAO, LAO, good with that. Note, think of the oblique view as turn to the left or right, shoulder forward. I'm good with that. Craniocaudal, good with that. That's not enough nomenclature, I need some more. Angiographic projections made simple, an easy way to understand oblique views. Okay, here we go. Trainees in the catheterization laboratory need to understand coronary angiograms and how the arteries change position with specific angulation. The following section illustrates how the heart and the coronary arteries move in the different projections. The changing positions can be easily remembered by using the left hand as a representation of the coronary tree as it sits over the heart and changes position with different angulations as the right and left shoulder is rotated toward the two to duplicate LAO and RAO views. The cardiac silhouette in left anterior oblique and right anterior oblique. The heart is the size of one's fist. It is shaped like an ice cream cone with the tip toward the sternum. The open hand is positioned as it would be seen in AP projection. When the left shoulder is moved forward, LAO projection. The hand is seen more on the end the heart is made shorter and rounder in the LAO. Okay, let me look at the pictures. Okay, there we go. Gotcha. AP. Okay. Okay. When the right shoulder is moved forward, RAO projection, the hand is seen in profile. That is, the heart is made longer, with the tip extending to the left chest wall. These movements of the hand in the LAO and RAO remind you how the heart should look in each projection, whether seen on a plain chest x-ray or a fluoroscopy and ventriculography during cardiac catheterization. Okay, good with that. Okay, AP, LAO. Okay. Left ventricle diagram in the patient as the LV shape changes from anterior posterior to the left anterior oblique and the right anterior oblique. Synangiography frames of left ventriculograms in the LAO and RAO. LAO segment basal, lateral, apical, septal, RA segments. Okay. Okay. All right, I'm getting there. Okay. I'm going to call it because I'm getting into some nitty-gritty stuff and I need to take a break. And I'm ready for bed. And this is going to get really it's going to get really in depth, I think. All right. That's all I got. Have a good one.